the topic today is 4 perspectives on DSM-6, and I chose to talk about it because I was in a discussion with someone at the American Psychiatric Association, someone who has an important role in the future of the DSM, and the discussions about what DSM-6 will look like have begun, and apparently there's a lot of interest in doing something very different in DSM-6. And part of it apparently is spurred by a certain amount of healthy competition with the ICD-11. And I'll talk a little bit about the ICD-11. But there's a sense of wanting to innovate, partly in response to ICD-11. And there'll be a series of symposia, apparently, over the next couple of years. And then I was asked to be in one at the annual American Psychiatric Association annual meeting in the spring about the future of the DSM. And I was asked to talk about the perspectives as something that might be incorporated potentially into the future DSM. So, got me thinking. I thought I'd share my thoughts with you. So first of all, I must say I didn't know much about the International Classification of Diseases, or the ICD. It's a product of the World Health Organization, and I guess in the ICD-10, which is not the current version, but the last version, the feeling was they actually needed different versions of the classification of mental and behavioral disorders in order to meet the needs of different users. Now, I don't know about you guys, I've certainly thought about that with regard to the DSM. You know, you're trying to serve a variety of different functions, and each function might ideally might benefit from having a different version. So for mental health professionals, the World Health Organization developed this thing called Clinical Descriptions and Diagnostic Guidelines for ICD-10 for mental and behavioral disorders, and they call it the Blue Book because it's blue, intended for general clinical, educational, and service use. And for each disorder, there's a description of the main clinical and associated features, followed by more operationalized diagnostic guidelines to assist clinicians in making confident diagnosis. Well, it's an awful lot like what the DSM is. And it turns out that while the DSM-4 was, this is, as of 10, 12 years ago, the DSM-4 was used much more often by researchers around the world. There was a study of about 5,000 psychiatrists in 44 countries, which said that for most psychiatrists outside the US, the ICD-10 was used much more in clinical practice than the DSM, 70% of the time versus only 23% of the time for the DSM. And another study said it is that CDDG version, Clinical Descriptions and Diagnostic Guidelines version, that is in fact what people tend to use. So, and then Michael First at Columbia and colleagues compared the two, the ICD-11, CDDG, and the DSM-5 criteria for 103 diagnostic entities, and found that 20 of them, 19% of them, showed major differences between the two classifications. About half the time there were minor differences, and 30% of the time they were identical. And they concluded the ICD and DSM are actually closer now than they've been since the 70s. So most of you probably know that the DSM was revolutionary. The DSM-3 in 1980 was revolutionary. It was revolutionary in that it was dramatic. It changed dramatically from the DSM-2. It took us from a psychodynamically focused way of thinking, classifying, to a medically oriented way of classifying. It was medical, and it promised to be biological. There was a lot of talk that this is the beginning of the so-called biological revolution, where we're going to understand disorders based on biology. It hadn't happened for when it came to DSM-4, it hadn't happened. When it came to thinking about DSM-5, people said, okay, now we're really going to have a genetically and neurobiologically informed classification. But it didn't really happen. The DSM-5 was actually not too much different from the 3 or 4. And I think it's fair to say, I think most people would probably agree there's been very limited progress on establishing validity through biology at this point. So when DSM-5 came out, there was this critique that, well, the biological revolution doesn't seem to have happened. And Tom Insel, who was the head of the National Institute of Mental Health, said, well, it hasn't happened because we haven't had the right approach to biology. We haven't sort of sufficiently tied the DSM-5 to brain systems and mechanisms. And they proposed this system that's gotten a lot of attention, RDoC, Research Domain Criteria System, that was meant to correct this. But another way of responding to the fact that the biological revolution hadn't happened was described by Susan Harrington in this 2019 book of hers, which I'll show you in a moment. She's a professor of professor of the history of science at Harvard. And she said, well, the medical and biological model, it hasn't provided a comprehensive approach to our patients' issues, and so it really can't account for what's happening with the patients, essentially. So here's her book, Mind Fixers, that came out a couple of years ago. Mind Fixers, Psychiatry's Troubled Search for the Biology of Mental Illness. No, I said Susan Harrington, Anne Harrington. She wrote, the Freudians lost credibility by insisting they could be experts on everything. And the new generation of biological revolutionaries repeated their mistake. And then she went on to say, for 4 or more decades, so she was talking about how the DSM-2 didn't work terribly well, but neither did the DSM-3, 4, or 5. And now she's going back in time before then, before any of them, for 4 or more decades, earlier in the 20th century, biological and non-biological approaches coexisted in American psychiatry, somewhat uneasily but largely peaceably. A détente that was partly enabled by the leadership of the today almost forgotten psychobiologist Adolf Meyer. Of course, he's near and dear to our hearts as the founder of our department. And this is a quote from Meyer in JAMA 1917, and I show you here the original DSM in 1952 because Meyer's psychobiological framework played a major role in framing how this original DSM was put together. This quote from Meyer's JAMA article is, psychiatry cannot limit itself to the traditional asylum diseases. The principal departure from tradition is the inclusion of normal psychobiological adaptive problems and the getting away from the dogmatic notion of one person, one disease, dictated by a classification-ridden tradition, and from a nosology which neglects too many points important for the understanding and treatment of the actual patient. So, in terms of thinking about frameworks for understanding psychiatry, certainly the one probably I think the greatest number of people are taught in medical school and residency is the biopsychosocial model. And George Engel was the person who created it, and he was a graduate of Hopkins Medical School in the 1930s when Adolf Meyer was still the department chair. And in his science paper from 1977, he cites Meyer. He cites the Meyer paper that I just referenced and refers to his inclusion of psychological processes and reaction to life stresses as part of more integrated and holistic concepts of health and disease. So, Ken Kendler is one of the leading researchers and thinkers in our field. He's pictured here at Virginia Commonwealth. here in the American Journal of Psychiatry paper, he wrote, in the tradition of other thoughtful commentators, especially Engel and McHugh and Slavny, in place of biological reductionism, I advocate explanatory pluralism. I emphasize pluralism because it's a good word that's been used a lot by people who are thinking about these issues, as the approach best suited to understanding the nature of psychiatric illness. Now, why don't we use, why as a department don't we embrace the biopsychosocial model? A lot of people do embrace it. Well, Kendler said it then in a later article, he said the biopsychosocial model, while making us feel good about our open-mindedness, offers us no critical guidance. In letting all flowers bloom, it provides no guidance. And Nasser Ghami, who's a very thoughtful guy in this arena, who's written a couple books trying to think about the structure of psychiatry, one of them being the concepts of psychiatry, a pluralistic approach to the mind and mental illness. Nasser Ghami said the psychosocial model gives mental health professionals permission to do everything, but no specific guidance to do anything. So the perspectives approach does provide guidance. It points us in particular directions, and again, most of you are well acquainted with this outline, but I'll just remind the few of you who may not be, it recognizes 4 ways of thinking about the nature of patients' problems, and one of them is the disease perspective, the biomedical approach, which again is the foundation of what the DSM is built around. One of them is the disease perspective. The other 3 come from psychological traditions. And thank you. I think I saw Dean McKinnon kind of crystallize this for me. That these 3 other perspectives really come from psychological traditions. Life story from the interpretive psychology tradition, behavioral perspective from the behavioral psychology tradition, dimensional perspective from the experimental psychology and psychometrics traditions. And, so one of the key distinctions that helps frame the perspectives is this distinction that comes from Carl Jaspers, who wrote this great book, General Psychopathology. I think it was the 1930s that he wrote it. And Jaspers was a psychiatrist who became a philosopher, and he's very concerned with this concept in philosophy of epistemology. How do we know things? What is the nature of knowing? And this distinction is a wonderful distinction between knowing through explanation and knowing through understanding. Explanation, we find by repeated experience that a number of phenomena are regularly linked together, and on this basis we explain causally. It's it's a mechanistic way of knowing. And understanding, we sink ourselves into the situation and understand by empathy how one psychic event emerges from another. And explanation, the mechanistic way of knowing, is how we make sense of brain diseases. This graphic is something that I put together with help from some graphics people in our marketing part of Hopkins. We came up with the graphics, but the concept here, it comes right out of a New England Journal of Medicine commentary by Paul McHugh and Philip Slavny from 2012. So by contrast, an empathic understanding is the approach we use to knowing things in the life story perspective of psychiatry. I'll come back to this clustering concept later. So I'll just say, I won't say much of anything about the disease perspective because I think it's so well known to all of us. I'll just say a word about it. In the disease perspective, which is the way doctors think about medical diseases and the way psychiatrists think about psychiatric diseases, there's a clinical syndrome. It has a pathology, various pathologies that can underlie it. It has various etiologies that can set the pathologies in motion. It creates a lot of clarity. There's the clarity that if you meet the syndrome definition, there's a specific biological treatment that's implied. And of course, schizophrenia implies using antipsychotics. And Major depressive disorder implies using antidepressants. OCD implies using high-dose SSRIs. But I'll focus on the other three perspectives, which maybe are, in some ways, I think at least to psychiatrists anyway, are maybe less completely obvious. The life story perspective is about what a person's encountered that might lead to feeling overmastered or demoralized. That's kind of a conception of it that comes from Jerome Frank, who was a longtime giant in the department in the realm of psychotherapy research, and he published Persuasion and Healing that many of us have read as part of our curriculum for training residents. And it's really the opposite of checklists and categories, because as our patient pointed to at the end of our little discussion, each person's story is intricate and unique. And it's one of the beauties of taking care of patients and engaging in psychotherapy with them is that you can spend enormous amounts of time getting to know what's unique and special about that person. And as our patient pointed out, the uniqueness can sometimes belie certain assumptions, preconceptions you might come in with. So in order to do a good job in kind of working through a patient's story, understanding it, you have to get to know it in great depth. And in order to help a patient reframe things, you really need to understand what they've been through. Life story kind of approaches are especially useful when it comes to dealing with stressors, dealing with grief, dealing with medical illness, which can be a big stressor. And in fact, it's in the realm of medical illness that a lot of the academic empirical work around life story has occurred. The consultation liaison psychiatrists have actually thought a lot about Jerome Frank's demoralization concept, because they're often dealing with demoralization in the setting of serious illness. And so a demoralization scale got created. This was a paper looking at a second version of the demoralization scale. And when the demoralization scale has two components to it, and one of them is really focused on meaning and purpose. And certainly meaning is a very central element of the life story, what kind of meaning gets attached to people's experiences. This paper focused on people with cancer and other progressive diseases. And these scales were administered, and the meaning part of the scale has questions, has things that get rated, such as the statement, there's little value in what I can offer others. My life seems to be pointless. My role in life has been lost. And the authors conclude that this scale is likely to be a useful clinical and research tool in meaning-centered therapies when patient populations are at risk for demoralization. Meaning has come up in our department. In particular, people have explicitly called out the issue of meaning in the Psychedelic Center, the Center for Psychedelic and Consciousness Research. The paper that Roland Griffiths led, which is considered the paper that launched the psychedelic renaissance in the world, this 2006 paper, included this figure about people's response to how personally meaningful was this experience you had with psychedelic, psilocybin-assisted psychotherapy. And famously, more than half of people called it one of the top 5 most meaningful experiences of their lives. A paper 10 years later from Roland and the group looking at the treatment of depressive and anxious symptoms in people with cancer showed on the one hand that psilocybin-assisted psychotherapy treated the depression and anxiety, but it also showed that the degree to which the experience was powerfully meaningful correlated with the experience on the score on a mystical experience scale. Let me turn to the issue of dimensional traits, which are about who we are cognitively and temperamentally. This comes out of the logic in this perspective is about a continuum as opposed to something being categorically either or. And so in the realm of cognition, there are lots of continuous scales like IQ. In the realm of temperament, there are continuous personality scales that focus on dimensions like extroversion and neuroticism or instability. And here's the figure from Hans Eysenk's 1963 Nature paper. Eysenck was one of maybe the leading personality psychologists in the world at that time. And there's an extroversion, introversion scale and an unstable, stable scale. And of course, provocations play on vulnerabilities and can lead to maladaptive responses. And importantly, in this perspective, we're not only looking at vulnerabilities, we're looking at strengths. And of course, that's an important thing to keep in mind when it comes to taking care of patients. As many of you may know, the DSM-5 actually thought hard about dimensional approaches to personality. In fact, they thought so hard about it that they decided that's what they preferred. That is to say, the committee focused on personality in DSM-5 decided that they wanted to use a dimensional approach to thinking about personality. And they approved it, and everybody approved it in the DSM-5, but the Board of Trustees of the American Psychiatric Association overruled them and said, no, we're not gonna make that change. It's too impractical. And so they put it in the back of the book in something that's sort of the unofficial emerging measures and models. But so it's interesting, I don't know if anybody's ever looked at it, but there's been a lot of literature about it ever since 2013. The way they structure it, they have a criterion A in this, what is now called the alternative model for personality disorders, this dimensional approach. They have a criterion A which is essentially about how impaired a person is in various aspects of personality functioning. So they look at how impaired you are in terms of your identity, your self-direction, your empathy, and your intimacy. And if you're impaired on two or more of those, then you've got a personality problem. And then you look at 5 domains and 25 facets to sort of characterize the kind of type of personality problem. Interestingly, one paper in 2011 said that psychiatrists, when polled psychiatrists around the world, prefer a dimensional approach to a categorical approach. I thought that was pretty interesting. I hadn't realized that. The majority of them said that they prefer a dimensional approach because it can provide a more accurate reflection of psychopathology, and also because it can provide a more detailed and personalized approach to diagnosis. So again, an important part of the dimensional perspective, to my mind, is this fact that there's positivity. There's a focus on the positive and not just the negative. And Seligman said in 2000 about positive psychology, the exclusive focus on pathology that has dominated so much of our discipline results in a model of the human being lacking the positive features that make life worth living. A meta-analysis of positive psychology approaches that came out recently showed that they tend to work. And they use things like, for example, these components that I refer to as using your strength, the 3 good things, and the gratitude visit. So using your strength, participants are asked to fill out values in action inventory of strengths and to think of ways to use their top 5 strengths more in daily life. This is one example. Moving on to behaviors. Of course, behaviors are about what people choose to do, often motivated by physiologic drives. They're shaped by prior experience, things like rewards and punishment and cues. And they deal with behaviors like eating, sleeping, sexuality, substance use, sick role behavior. As one example, CBT for insomnia focuses on behavior change as a way to improve sleep behavior. Here's a paper from a couple years ago that looks at sleep restriction therapy. It was on my mind because a patient of mine received it from our behavior group recently and had tremendous benefit from it. That can involve regularization of time in bed, but also restriction in the amount of time in bed, and both of those things seem to contribute to improvement in patients' behavior, sleep behavior. And certainly behavior therapies are used all the time in treating substance use. Here's just one example. Of course, substances are reinforcing through innate hedonic drive processes. Contingency management is the idea that reinforcing behaviors will increase their frequency, and it's based on providing reinforcement that can compete with drug reinforcement to promote abstinence. And one approach to this is to offer people entrance into a prize draw if they remain abstinent. And so when this was done with alcohol-dependent veterans at a VA, 69% who were part of this prize draw contingency management, 69% of them remained abstinent through the end of treatment, as compared to only 39% in standard care. So, using the perspectives, to use them effectively, you have to really thoroughly assess patients. And so one of the things that's so wonderful about the perspectives is that it drives thorough assessment, which is so key for our Hopkins approach, and I would argue for any good approach to taking care of patients. So, and thanks to Zach Cordner, I think it was Zach Cordner and Dean McKinnon and Ray DiPaolo who wrote this very nice review paper that I drew on here. The thorough Meyerian assessment becomes a form of role induction for the patient to reflect on all the aspects of their life that could potentially be salient to treatment. It establishes a therapeutic alliance through the act of the patient entrusting the clinician with their life story. And the fact that the clinician takes so much time and effort in the process instills a certain level of hope and confidence in the patient regarding the fact that they're in the right hands, they're in good hands, the people who really care about them. And therapeutic alliance itself, which is built through this process, has been shown to predict clinical outcomes across all kinds of treatment approaches. Again, here's one example from the substance abuse literature. If among opioid-dependent patients, those who have a low level of therapeutic alliance with their provider generally are not all that likely to complete treatment. But people who have a high level of therapeutic alliance are far more likely to complete treatment. In addition, we were talking about using all four perspectives, and that has great value. It has great value because each perspective can actually help therapeutically. It can guide you to a particular therapeutic direction that can be useful. But in addition, when you take this sort of approach, you tend to get more clarity about the nature of the disease that they have. The disease itself becomes more clear when you think of it, when you understand in the context of the things that are going on. And here's a really nice paper from Russ Margolis and colleagues. I'm trying to remember who the second author is. Krista Baker, I think. This is from the Schizophrenia Consult Clinic here. And these are 83 patients referred to the clinic. Now, before coming to the clinic, the patient records are reviewed, tests are done, questionnaires are filled out. The consult involves interviews with the patient and an informant. It's 3 to 4 hours. There's an the evaluation is performed by a senior psychiatrist, endotherapist. There's a whole lot of discussion. When all that's said and done, what the team got was a lot of clarification about the diagnosis. 43 people came in with the diagnosis of schizophrenia or schizoaffective disorder. And it turned out only half of them, after all of this careful review, had that diagnosis. And the other half had things like anxiety disorder, major depression, bipolar disorder. So the broad thinking clarifies disease. So all that said, the task, my task when I get to the American Psychiatric Association meeting, and luckily it's still 6 or 8 months off, and so I have time to do more thinking and hear good ideas from all of you. But, how can the perspectives inform the DSM-6? Well, it seems like one obvious thing to do is to say, well, look, the dimensional approach that 10 years ago people thought made sense probably should actually be adopted. The dimensional approach to personality should probably actually be adopted. And then the very wise suggestions that Paul McHugh and Philip Slavny had 11 years ago probably make sense too. That is to say, the disorders in the DSM probably should be grouped into things that are clearly diseases like schizophrenia, bipolar disorder, and OCD. And the behavioral problems ought to be grouped: sleeping, eating, sexuality, substance use, abnormal illness behavior. And the things that are more clearly reactions to life circumstances, bereavement, adjustment disorder, acute stress disorder, probably ought to be grouped in a kind of life story way. And I realized that this actually has some resemblance to what was the old multi-axial system, but is no more in the DSM-5. They got rid of it. But I guess that's something like what the multi-axial system was trying to do. The axis 1 was about diseases. Axis 2 was about traits. It was about cognitive and personality kinds of issues. And axis 4 was about psychosocial and environmental issues, which to some extent is life story issues. So I suppose at one level I'm arguing for bringing back the axes in a maybe more refined and effective way. So to wrap up, so we have a little bit of time for discussion, the ICD-11 CDDG looks a lot like the DSM-5. The biological revolution hasn't happened, and the disease approach of the DSM is unlikely to fully account for patients' distress. The perspective's focus is both on disease and on 3 psychological paradigms. And using all 4 perspectives leads to comprehensive care of the disorder and the person, and it requires comprehensive evaluation. And incorporating the perspectives framework into the DSM-6 will lead to enhanced therapeutic alliance, greater diagnostic clarity, and a framework for a multifaceted approach to treatment. With that, I thank you. Love to hear what you all think. Thoughts, Joe?
I have a couple of contributions to this conversation.
Terrific.
So I love hearing all the, some of this history is brand new to me. But with regard to the DSM-5 and ICD-11, it's no mistake that they're matching up better. That was actually by design. I think there were people on WHO committees as well as DSM committees.
Mm-hmm. Mm-hmm.
I was actually a little disappointed in having them come together just because the ICD sort of matched sort of the history of anxiety and depressive disorders classification better than the DSM did. The other part of the conversation was I understood a different bit of history about the personality disorder section, and that was that I thought that the board said you guys needed to study this more before we make a wholesale change. And I guess one thing that it would do is it would get rid of all of the existing personality disorders, is my understanding, which I think could be problematic for example, people who created clinics to treat patients with borderline personality disorder. Those are my thoughts. Thanks.
Those are great thoughts. Thanks. Yeah, you know, on the ICD and DSM coming together, right, you know, I guess I was thinking about how many of us academics both collaborate with people around the country and around the world. And of course, collaboration is a wonderful thing. And we also compete with them. And I think that's actually probably not a bad thing, that, you know, having both collaboration and competition is probably a healthy thing. You know, in that competition spurs people to think harder, but collaboration, but getting on the same page has tremendous value too. So maybe both of those are good. Yeah, no, my understanding is the same as yours, that the idea was that more research is needed before the dimensional approach would be adopted. They weren't throwing it out and saying, put this in the trash and never think about it. They're saying, keep working on it. We want more research before we can make up our minds. Graham. Yeah, no, very good point. I was thinking about that. You're right. I mean, the Diagnostic and Statistical Manual is about counting. You know, originally it was about counting things. How many of, which partly was about planning for services. How many psychiatrists will we need to, you know, in the Army or in a given state in order to take care of the needs of people? I think you're right that it's not currently intended to directly influence treatment, and maybe, and I'm not sure whether this argument that people are pointed in a therapeutic direction by the perspectives will hold water for the people who think about the uses of the DSM. I'm not entirely sure. Glenn.
Well, Jimmy, I love that talk. That was great. Thank you so much for bringing us to this place. One of the things that you did mention the issue of treatment early on. You didn't mention the issue of research very much. And one of the strengths of the perspectives not only does it talk about treatment, it also talks about how to make progress in these different areas. Because you can be Bob Conjure and look forever for the gene for extroversion, but it's an extremely polygenic element. And you can look forever for the lesion in the brain for alcoholism, but it is an extremely complicated set of circuitry that drives motivated behavior. So this approach that you're proposing for the DSM not only allows us to estimate something about what we would do treatment-wise, it allows us to think about, you want to ask the question, how many psychiatrists does it take for the Army? Well, these people have these dimensional personality traits that will make them this vulnerable to PTSD, and therefore you need this number of psychiatrists to address that issue in this subgroup of people where you can measure personality traits, and you can say this number of people at this age will develop schizophrenia because you can look at the disease element of a group of patients. And this number of people will be catastrophically responsive. And then you can say, well, why do these people develop these extreme reactions to life story events? We'll look at their temperament and their genetic vulnerability to affective disorders. So it gives you a way to go forward in terms of description. It allows psychiatrists to read more on what's wrong with patients. People like including dimensions, and people like including life story. But it also allows us to think about the science that informs each of these different perspectives. And I think that's why it's such a powerful method. I appreciate you bringing it back up.
Thank you, Glenn. I'm tempted to respond, but we're just about out of time. I'll give Karen the chance to.
One of the most important messages I think you can take to the APA is that with this wonderful comprehensive approach, we as psychiatrists need to move past the idea that in 15 minutes we will decide which pills to change.
Yeah. Yeah.
That is what if we are going to be real psychiatrists, of course we want to approach our patients in this comprehensive way. And I think as a field, we have abdicated our responsibility to do that. And I think we need to take it back.
Yeah. Yeah. No, I think you're absolutely right. And of course, again, we're out of time. And so maybe I'll conclude with this statement. I apologize. There's much, obviously, vastly more to be said. And I'd love to hear from all of you in person or by phone or email with any thoughts you have, because I really want to think hard about this as I get ready to go talk to the field as a whole. But yeah, I will just say that one of the big challenges is we all agree that an hour or 2 or 3 or 4 is a lot better than 15 minutes in terms of doing a good job. The big question is, how do you make that practical? How do you make that work practically for people whose time is constrained? If anyone has great thoughts about that, I'd love to hear it, because that is a big, important practical question. Thanks, everybody. Appreciate your coming.